Welcome to this American College of Surgeons Healthcare Forum emphasizing quality. This is part of a national tour of sorts that the college is doing to try to bring this message of quality to all of you.
Andy and I are really pleased to be here, to be able to chat with you, to have a dialogue with you about issues surrounding quality and healthcare. Today's remarks will focus on the value proposition, that quality surgery not only delivers better patient outcome, but also delivers better financial outcomes. Surgical care makes up half of the annual healthcare expenditures for inpatients nationwide. The simple fact is that improving surgical quality is a critical and often overlooked tool in improving healthcare outcomes and cost. We believe that if physicians and surgeons and hospitals are better engaged in these important dialogues, then we're going to improve all of the aspects of care, quality, access, and cost. And we hope that out of today, we'll be able to share some of the ideas into things that we can apply directly to our hospitals.
Surgical quality obviously matters everywhere in this country, but we have special pride here in Boston because this is where Ernest Amory Codman, more than 100 years ago, founded the quality movement. Due to his influence, Codman really led to this kind of structure of what one must do to ensure quality. Effective quality improvement measures outcomes improvements. And the poster child, as far as I'm concerned, is the National Surgical Quality Improvement Project of the college.
Providing high quality care in a mass unit gets sort of difficult. And if we don't watch ourselves, I mean, the level of cost containment that people are talking about, that's where we could wind up. The hospitals and the physicians and the various groups of physicians are not on the same page all the time. Not a way to run a railroad at the end. And what's even worse is when we combine pre-hospital care, hospital care, post-hospital care, you're not talking to each other. That needs to change. But the reality is there is a significant amount, not only of the policy community, the medical community, that views you as the problem. That's why I'm so pleased about this discussion you're having. And the fact that, and I like that tagline, the idea that, now we're going to make a difference. You're not going to be part of the problem. You're definitely going to be part of the solution. So where do we go from here? Outcomes are critical. And it builds into where your philosophy is. So the question is this enough by itself to lower costs and improve value? No. I'm sorry. It is not enough. But it is a great start. And again, Mike, thank you for inviting me. You're really on the right track.
But really the focus has been on inspiring quality locally and improving the quality of surgical care. The key aspect to that is measuring it. Having quality metrics of data that you trust, data that reflects the care being given, high quality data. High quality data is risk adjusted, it's prospective, has standardized definitions so that a urinary tract infection at Mass General Hospital is the same as a UTI in North Dakota. Having that kind of information is the key in order to improve the quality of care at your hospital.
And when my patients have complications, they use capacity, they use resources. And when there's limited resources, the only way to expand your resources is to get more benefit out of your dollar, which is all about improving quality. Whenever I have a complication, somebody's suffering. It's not just the patient who's suffering. But when my expenses go up for taking care of that patient, because there's constraints on resources, somebody somewhere isn't getting something they need. And so the problem of bad quality is much bigger than simply the delivery of care to the specific patient. I believe that the real untapped power within our systems is the desire of surgeons to deliver the right care to the right person.
I think the most interesting part about the discussion so far are two things. First is that we know what to do, and that wasn't the case 15 or 20 years ago. We now know that we have approaches to try to align the payments so that when people are pursuing better quality and lower costs they aren't penalized for. We've also recognized that we have to be able to measure the results, which is why registries like NSQIP that tell you about the specific kinds of issues that surgical patients have, or the specific kinds of issues that cardiology patients have, or the specific kinds of issues that childbirth patients have, give you a lot more about the nuance of why some places are better than others. Where we're struggling is with how to begin to implement and package all of this together so that it happens at large scale.
Seriously, I want to congratulate the surgeons here with me and the American College for taking such a leadership role in the area of quality. I think if you look across all the specialty organizations in this country, I don't think anyone has sort of carved out this niche as effectively and with as much vigor as the American College of Surgery, and so I just want to congratulate you and your specialty for doing just that.